So we're moving on to the last part of our section. This one is an interesting case. So I think Dr. Amarit will present the case about the TEVAR in Type B aortic dissection extending to the arch. He will have the case sharing with us. Maybe we need more discussion about the cases. Thank you.
Thank you, Chairman. It's my honor to be present. So this my interesting case is a TEVAR in Type B dissection extending into the aortic arch. Yes, it's not Type B because it's extends into the aortic arch. So we call that type non-A, non-B as a discussion in the panelists. So when the TEVAR will extend in the aortic arch, have the indication for users. Yes, it's up to the proximal landing zones. If they have the use for the extension to the aortic arch, first is we maybe intend is to worry about the proximal landing zone. So the TEVAR maybe have a role in the TEVAR zone 2, TEVAR zone 1, and of course for the residual dissection after first repair of the Type A dissection and have a residual dissection that the aortic arch still have a dissection. So the TEVAR maybe have role in all of this disease. So let's start on the first cases for the TEVAR zone 2. The first case is acute Type B dissection for male 67 years old. He presents with intramural hematoma on the upper part, and for the distal part is a dissection below the T7. The patient first come because it's a Type B dissection, so the medical treatment has used for this patient, but after the follow-up, the CT, we found that the progress of the disease, so we decide to perform the endovascular treatment in these patients. As we see the CT progression and the patient have uncontrolled hypertension during the treatment, so the endovascular repair may be decided to be treated for these patients. One more thing on these patients, when we focus on the intramural hematoma, we focus on the outside projection as the primary, like a primary entity for the aortic dissections. So for these cases, the outside projection is start from the distal to the subclavian artery, but the intramural hematoma is extended into the arch, around the arch zone 2. So for the treatment for these cases, we decide to use the proximal landing zone, start on the outside projections, but not start on the extension to the arch of the intramural hematoma, because if we start to use the proximal extension from the intramural hematoma on these cases, the arch branch of all arch branch may be involved, and maybe we need to do the zone 0 or we do the open to the total arch repair like this. So this case is decided to do the TEVAR on zone 2 to cover the outside projection on the distal of the aortic arch. For the procedure is use the left subclavian translocation and do the TEVAR by the bottom-up technique by the use the Medtronic stent. The proximal landing zone is on the distal to the left subclavian, and the distal landing zone is above the celiac, above the 7 centimeters. So this is the result for after we deploy the stent. We see the stent is good, but no endoleak and no extension of the intramural hematoma after we follow up for the CT. So this is the CT follow up for the patient. Very good. No endoleak, no bird beak size, and very good stent frame to recover for the disease. After we follow up the patient, the CT angiogram, after we perform the first TEVAR for 3 months and 1 year, we see that the stent is good and the aortic at the area of the stent frame is remodeling. The hematoma is gone and no disease left. And follow up for 1 year, the aortic is done not expansion in this case for the TEVAR zone 2. So the conclusion in this case is a little bit dangerous, because if we talk properly by the guideline, the disease is start on the aortic arch. We should need to be use the proximal landing zone on the start of intramural hematoma, but if cannot avoidable like this case, maybe a little bit safe to do the TEVAR zone 2 and follow up the CT. For this result for this case is no endoleak, no arch enlargement, no retrograde dissection, no stent migration, and pattern of all the arch band and good remodeling of the aortic arch for these patients. The second case is a TEVAR zone 1. The TEVAR zone 1 by this case is also the type B, acute type B dissections. But for this case, we see that he has a sacral rhythm on the aortic arch. And next to the sacral rhythm of the arch, we see the dissections, and the dissection extend to the bilateral of the superficial femoral artery. As we see for these cases, we see the sacral aneurysm, and the next is the aortic dissection type B. So this case, indication for the surgery for type B is maybe not strong, as he has also the sacral rhythm of the aortic arch. So it's the same disease for this patient. So this patient is designed to perform the endovascular treatment involving the aortic arch due to the sacral aneurysms. So for this case, the proximal landing zone is also proper for these cases. This case performed the right carotid, left carotid, and left subclavian bypass as seen on the scheming on the screens. And do the TEVAR also do by the bottom-up technique for the TEVAR because of the dissection and the distal landing zone is very small. So we use the bottom-up technique. After follow-up for these patients, you see where the stent frame and the aortic remodeling is also good for these cases. Even he has a sacral aneurysm. So when we follow up, the sacral aneurysm is thrombosed, and for these cases, the dissection, the residual dissection has not occurred for this case. It's like a completely remodeling of the aortic. When we focus on the aortic arch that has a sacral aneurysm, follow up by the CT, the size of the aortic arch is not increased in 1 year after the follow up for these cases. So the conclusion for these cases, aortic arch zone 1 also safe in the patient with the extended into the aortic arch lesions, no endolesion, no arch enlargement, and stable during the follow-up, no retrograde protection, and no stent migrations. And for the last case of the sample case is the patient maybe perform the previous type A dissection and have residual dissection just like a type B. For these cases, the patient has a 64 years old male and present with the type A aortic dissections. In my hospital strategy, we also perform the hemi-arch or partial arch replacement with the innominate translocation because maybe the patient need further endovascular repair and easier to do the proximal landing zone. As these cases, TA follow-up after we perform the hemi-arch replacement with innominate translocations, the residual dissection also patent. For the CT, we see the proximal is good because it's all replacement by the graft and use the translocation, and we also marking for the proximal landing zone in the CT. So this case, after we follow up the CT, we also perform the endovascular repair by TEVAR and also do the carotid subclavian bypass, and the same as the second case. And we deploy the standard TEVAR as a bottom-up technique because also even the patient have a chronic dissection after type A dissections, the lumen also very small in the distal. The bottom-up technique may be safe for the patient like this to prevent the sign in the future. So the CTA follow-up for this patient, we see that this case is look maybe better, but they have some problem about the false lumen. As we see, the false lumen is still patent and have a partially thrombosis in the false lumen. The CT for the 1 month after we perform the TEVAR, we also see the the contrast also pattern in the false lumen, and the CT found that it's the persistent fold from the left subclavian, which connect to the residual dissection from the left subclavian origins. That we also put the stent in the aortic arch to cover all of the aortic arch branch, like carotid, because we translocation the illuminate, and also left the carotid and the left subclavian, and also we perform also embolization on the proximal origin of left subclavian, but the dissection also pattern in the patient by the false lumen from the left subclavian connect to the false lumen in the aortic arch into the descending aorta. So we do the embolize again on the left subclavian, and after that the CT also show no endoleak type 2 from the left subclavian at all. But even we follow up for the CT for this patient, after we perform the intermediate translocation and do the second operation by the TEVAR and coil embolization again, the follow-up CT above 1 year, the aortic arch also increased in size and the pattern of the false lumen and just only partial thrombosis and the proximal aorta and the proximal descending aortic arch and distal aorta at the descending level on the around 3-9 level, also enlargement during the follow-up. So, for the conclusion in this patient, TEVAR extended into in the residual dissection. If we perform the endovascular, it's still no endoleak, but even we cover all the arch band, but false lumen can be patterned from the residual band dissection, maybe cause of the endoleak, like in this case. And the arch enlargement may be also progressive, maybe because by the false lumen, and we did not perform occlude or the primary anti-tear in the descending or in the abdomen part, so the false lumen still pattern and the aortic still enlargement. This case is also planned to do the redo operation by open thoraco to replacement of the descending aorta, even they have the stent again in not far from now. So even no stent ligation, and the patient still need to be redo intervention by the reopen technique for these cases. So for the conclusion for the TEVAR that extend into the aortic arch, proximal landing zone may be safe in the aortic arch because the stent maybe also can get rid of the anti-tear or the residual dissection in the arch, but they need to be follow up the CT for further in the complication, like in the last cases that I show in the endoleak type 2 into the false lumen, and no retrograde dissection even we put the stent into the aortic arch. Thank you to the stent property by the Medtronic that retrograde dissection is very low in this type of the stent. And for the distal landing zone, we avoiding the oversight by use the bottom up technique is more safe. And when we do the arch for the stent operation, left carotid, left subclavian bypass also needed. Thank you for my presentations.
Okay. Thank you, Dr. Amarit, for your interesting case. So for the third case, I have two questions.
Yes.
One is that what's the consideration not doing the one-stage procedure? Because I saw that you do the hemi-arch and then later you perform the TEVAR, right? Or you do in the one stage?
Yes. No, we not do the one stage. We do the two stage because about 30% of our patient to do the hemi-arch with intermediate translocation, the disease may be not progress. So maybe someone have a aortic remodeling and someone maybe turn into the chronic dissection and the size of the dissecting aneurysm is not enlarged. So we don't need to do anything about this kind of the patients. But the half of the patient have an enlargement of the aortic residual aortic dissection. This type of the patient have need to be do the TEVAR. So we do the second stage operation like in the subacute phase is more safer than do in the acute phase.
And my second question is that because the continuous growing of the false lumen, so did you investigate into the distal tear for this case? Because I can't see the angio for...
Yes, for this case, the third case is we see the many anti-tear in the abdominal level and distal to the stent. Even the patient didn't have a sign, but the false lumen still going to the increase in the size. So we think the patent false lumen, even we get rid of the endoleak by the subclavian, maybe one cause from the residual anti-tear in the abdomen level.
Because in our experience, we think that in this kind of situation, that after you do the TEVAR and also this ascending repair, so if you still have growing of the false lumen, we will investigate into the distal tear and we try anything to stop the retrograde flow, because it will rupture in the future.
Yes.
And we can't predict the duration. Maybe it's fast or maybe it took like 1 or 2 years.
Yes,
so we will definitely go into investigate the distal tear.
Yes.
So any question from the panel for this case? No.